PC was working better than Mac.
All right, we are officially being live streamed. All right, thank you everybody for joining us tonight for Neuropsychiatric Manifestations of Lyme Disease. We have two really great panelists who they go way back with each other, way back with Lyme disease, and that is Dr. Brian Fallon and Dr. Robert Bransfield. Dr. Fallon is the director of the Center for Neuroinflammatory Disorders and Biobehavioral Medicine and the director of the Lyme and Tick-Borne Disease Research Center at Columbia University. He is a graduate of Harvard Law School, attained his MD degree from Columbia University College of Physicians and Surgeons, and also has a master's degree in public health epidemiology from Columbia University. Dr. Fallon's research has been supported by the NIH, New York State, and several generous foundations, including the Stephen Alexander Cohen Foundation, which is a partner of ours. We also have Dr. Robert Bransfield, who is a psychiatrist with over 40 years of experience. He is recognized by the Lyme world as being at the forefront of treating psychiatric symptoms of tick-borne illness and has dedicated his life to bettering the lives of patients. Dr. Bransfield is an advisory board member for Project Lyme and currently lives in New Jersey, where he continues to work his private practice. So thank you again, everybody, for joining us. Thank you to the panelists. The goal is this presentation is to educate patients, providers, and the general public on neuropsychiatric symptoms of Lyme disease. And we will look to provide information on how to effectively diagnose and treat it with the hopes that it will help you all in the community to prevent and or lessen future harm caused by the disease. So I know I've done a lot of talking, but bear with me for one more second while I get to our introduction here. And I will start with Dr. Fallon by posing our first question of the night. Why is it important to discuss neuropsychiatric manifestations of Lyme disease?
I think the most important reason is because if you miss it, then you're missing an opportunity to help treat a curable infection by identifying it early in the course of disease. So most people think that Lyme disease is associated with a rash. They know that, but they also think of arthritis, but they often don't think of the other neurologic things. They often don't think of radiculitis, the painful shootings, nerve pains. They often don't think of the encephalopathy, the cognitive problems that occur with Lyme disease. And they may not think of the depression, anxiety, and the mood dysregulation that can occur with Lyme disease. So it's important to recognize because some patients, in fact, with those symptoms do have Lyme disease, and if you treat it, they can get substantially better. If it's not detected until a year or two later, then it can be harder to treat. And Bob Bransfield and I have been working in this area for many, many years. I remember when Bob contacted me in the early 90s to discuss this. It was so exciting to find another psychiatrist in the world who had an interest in this particular area. And he had some fascinating cases he was telling me about, and I had seen some as well. And so we started writing some papers together. So it's really important because if you think about 15 to 40% of patients with Lyme disease may have neuropsychiatric symptoms, especially those with later symptoms. It's not uncommon to have that psychiatric comorbidity.
I think that makes a lot of sense. And we see with many patients, the development of late stage, I believe 10 to 20% is the number that I've seen thrown around based off of research. So another percentage of that developing neuropsychiatric manifestations. Clearly, this is a hot button issue and a lot of people are interested. So thanks for that response. Dr. Bransfield, I'll come to you second. How long does it typically take for patients who are in these later stages to develop neurological Lyme disease?
Well, there's some people that develop it very quickly and even a matter of weeks, but I think there's other people where it can be years or decades. The average person who comes, when I did an analysis, was 9 years post-infection. But some would be within the first year, and some would be 20, 30, even 40 years after infection. Now, I think there's some people where it's just a rapidly progressive infection that gets them early, and others, it may be slow and simmering, or it may be latent, and then it gets reactivated by trauma or stress or an auto accident. It can follow like a relapsing pattern. So there's a number of different patterns, and it's certainly easier to connect the dots when it's earlier. But the longer it goes, it's harder to see the connection. You have to take a thorough history to to connect everything. And a lot of the people that have the skill set for treating the early manifestation don't have the training usually to be able to assess the later manifestations, the neurocognitive and the psych symptoms that many of your specialists just really never had that training and had minimal training in psychiatry. So there's a silo mentality, we call it, or fragmentation, super specialization in medicine that interferes with progress in this area.
And I think we'll talk a little bit more later as to how we might address some of those issues in the education sphere of things. But clearly the two of you are experts in this, which is why you're here today as panelists. Dr. Fallon, I will move back to you here as we really get into the meat of things. What are the symptoms directly associated with neuropsychiatric Lyme?
Well, neuropsychiatric has two components, right? There's the neuro and the psychiatric. So if you want, you can separate them and say there's the neurologic and the psychiatric. So the neurologic, we think of as meningitis and encephalitis, which refers to inflammation of the brain. Meningitis is the stiff neck and the severe headaches and the nausea that might occur. You could have a facial palsy where the cranial nerves are affected, or you could have the shooting nerve pains, the radicular pain. So that's the neuro part. And then with the psychiatric, you might get a whole range of cognitive symptoms. It's not uncommon in early Lyme disease even to see some cognitive symptoms where people have word finding problems or brain fog and short-term memory issues. We just, my colleagues at Columbia just published a paper showing that verbal fluency is something that actually exists even apart from the memory issues that are associated with Lyme disease. So people have a hard time finding the words to say what they want to say, or they might put the wrong words in. So those are typical cognitive problems. And the typical psychiatric problems early on would be mood changes, irritability, anxiety, sometimes panic attacks, certainly sleep disorders. And then if you get a frankencephalitis where you have the spirochete perhaps causing inflammation in the brain, you might get mania, rarely psychosis. Personality changes sometimes occur where it seems like the spouse might say, my husband or wife is acting so differently than she ever used to act before. So these are things that can occur and do occur. Sometimes there's another syndrome called pediatric autoimmune neuropsychiatric disorders after strep infection. That's PANDAS. And you can also have neuropsychiatric disorders after other infections, and Lyme is one of them. And so that can be associated with OCD, anorexia, eating disorder type problems, and that can occur with Lyme as well. I'm sure Bob will have a lot to add to this as well.
Dr. Bransfield?
Well, I do an assessment, and after a while, I keep adding on new symptoms that I never thought of before. So my current way of assessing it is like 280 different symptoms. And when I tried to standardize it, I found the average person who doesn't have Lyme, and these are like medical students, and also the patients pre-infection, they would have 4 symptoms. The average patient with Lyme would have 82. And the average patient with some other chronic illness would have about 20 some. So there was a clear separation, but it was always different with each person. No two people had the exact same symptoms, but you would see common patterns. There would be common symptoms you would see, and then you would see some uncommon presentations that people would have, and you would see how it would progress over time. Like, for instance, the processing impairments, that goes with what we find with MRIs, where we find white matter. This is more of a white matter disease than a gray matter. And that goes with processing impairments, slow processing with reception or expression, or both. And it's also every now and then you see something new that I pay more attention to. Like recently, I've been paying more attention that it's different than attention deficit disorder, although there's some similarities. But a lot of Lyme patients have like a sensory flooding, or where they get overwhelmed by too much sensation. They can't filter it out, be it auditory, visual, like a nightmare would be Times Square. And I remember, Brian, remember we were assigned a meeting in Times Square for the American
Yes.
Psychiatric Association. And
Yes.
there were Lyme patients walking through Times Square with their sunglasses and their hoodies and their ear muffs on, trying to minimize it. But that's just where they assigned our symposium was Times Square at the hotel there. And so that's like a nightmare. And that's very different than attention deficit disorder, where it's more distractibility, although you have that too. So it's sort of like an acquired attention deficit disorder, but there's a qualitative difference. And innate intelligence is intact. And so there's things that are rather unique that you see. You see these intrusive symptoms that people have that they describe, be they intrusive thoughts, images. And it's so I go through, first I'll do a screen, then I'll go through the 280 symptoms and look at that before and course of illness and current. And then you figure out, well, where do you start? Do you give 80 drugs for 80 symptoms, or do you figure out how does it fit together? And what are the most critical symptoms that causes progression, perpetuation? And a lot of times that may be sleep deprivation, non-restorative sleep, or whatever stresses that person out the most. And it's different in other people. And then you work your way down the list. And you may treat the infection, you may alter immune reactivity, or you may treat the symptoms. Those are your three basic areas. And you educate too.
Yeah. And one of the questions people sometimes ask is, well, how do you know if it's Lyme related or it's not Lyme related? It's a psychiatric symptom totally unrelated, because it's absurd to think that, of course, that it's absurd to think that most psychiatric symptoms are due to Lyme disease. They have nothing to do with Lyme disease, but sometimes they do. And so the question is, how do you sort out who might and who might not? So you look for, at least I look for, are there somatic symptoms accompanying the psychiatric issues that are pretty typical, let's say, of a tick-borne disorder, such as paresthesias, numbness and tingling. Bob mentions the hypersensitivity to light and sounds. That's something that's somewhat unusual. I mean, you do see it with children who have autism. You might see it with individuals who have head trauma, but it's not that uncommon to see with patients who have Lyme disease. Someone who has no family history of psychiatric disorder and no personal history of psychiatric disorder, who suddenly develops a psychiatric disorder out of the blue at an unusual age, let's say 30 or 40, you really have to think that there's some kind of possible other cause, organic cause, and it could be the person has vitamin B12 problems, a deficiency, or a thyroid abnormality, but it could also be that they have an underlying infection. And so that needs to be considered. So those are some clues.
A big part of diagnosis is pattern recognition.
Yeah.
And you look, does it fit with this pattern, or does it fit with some other pattern of some other disease entity? And if you say, well, the test is negative, so it can't be Lyme, then you have to say what it is instead. That's makes more sense rather than inadequately treated Lyme. And I think that's a mistake a lot of people make, where they give excessive confidence in a negative test that doesn't warrant that degree of confidence.
Mm-hmm.
Well, as both of our doctors here did just mention, we're moving a little bit more into diagnosis, but I just want to recap that you listed a wide range of symptoms. And I think that merges very well with something you previously stated in one of your studies, Dr. Fallon, which is that neuropsychiatric aspects of Lyme disease are less widely recognized by physicians and often overlooked. Clearly, there's a lot of things that people need to know to be able to specifically identify it. But I'm curious why, I know you briefly mentioned it, but want to ask again, why is that statement true, and what is currently being done, maybe at Columbia, that is working on changing this?
Now, I think that the most obvious answer to that question is that the people rely on CDC surveillance criteria when they think about Lyme disease, and the neuropsychiatric aspects of Lyme disease are not mentioned in the CDC surveillance criteria. So unfortunately, many physicians think that that is the definition of Lyme disease, and anything outside of that isn't Lyme disease. So that's one reason. Another is that a lot of physicians like to see something objective. They like to see a swollen joint. They like to see a rash, and then they know that there's an objective medical problem. Psychiatric symptoms aren't something that you can see. As Dr. Bransfield said, there's pattern recognition, but you can't really see it. I started in the 90s looking at brain scans, brain SPECT scans, to see if that might help. And we saw a pattern that was similar to what you might see with lupus or other vasculitis diseases, where there's decreased blood flow in different portions of the brain. So that was actually helpful because it showed that there's something going on in the brain of these patients that's different from what you would expect. And then we did a PET imaging study and found also that there's blood flow, and there's also brain tissue uptake abnormalities. So once you start getting something objective that you can show, then people start to believe it. So I think that improved credibility. And then more recently, we did a study with this phenomenal group of epidemiologists in Denmark at the Mental Health Center of Copenhagen, led by Michael Benneros. And I thought, okay, look, Bob and I have spent all these years working on this, and how can we really nail it and ask the question for real? Is this really associated with Lyme disease or not? And people come to Bob because he's a psychiatrist. And if we do clinical series, people are coming to us with a mental problem. So that's a biased group. So what we did was we took the entire nation of Denmark over a 22-year period. Everybody in Denmark was included. And we looked at those who were hospitalized for Lyme disease compared to those who weren't hospitalized for Lyme afterwards. And we were looking at both suicide as well as mental disorders. And what we found, and we excluded people who had a previous diagnosis of a mental disorder from the Lyme group. And what we found was that those who had been diagnosed with Lyme disease in the hospital had a 28% higher rate of mental disorders than those who hadn't been hospitalized for Lyme disease. They had a 75% higher rate of
suicide. Okay.
Compared to those who hadn't been hospitalized for Lyme disease. And then association, which means that it's probably related. And also, if you had 2 episodes of Lyme disease versus just 1, that increased the risk of having mental disorders or suicidal behavior. So unfortunately, that's a serious, sad story that these mental disorders and suicide risk is indeed increased. But it was such a well-done study by those Copenhagen researchers that I think that a large member of the medical community now accept that as something that is definitely associated.
Dr. Fallon, I hate to share this with you, but you broke up during a portion of the statistics. So we got some of the percentages, but then we kind of lost you there for some of the other ones. It may be helpful because we do need to move on, but I would love to be able to share the link to that study with the community. So I will ask for that link to be sent, and I'll send it around when we send the video, just so people can review some of the information. I think the biggest takeaways that we got is that people who really had clearly severe Lyme disease ended up developing the neuropsychiatric symptoms, as you mentioned, and is why it's so important to really have a finger on the pulse of diagnosis. So
yeah, and there were 7 million people in that study, so that was a big study.
Huge. I can't imagine trying to attempt something of that scale in the United States. That seems crazy, but I would love to see it attempted. I'm sure that would be tough, though.
Right.
So really appreciate the answer. I think a majority of it did get across before you.
Fine. I'll send you the link. Yeah.
Awesome. Thank you. And just to continue moving on, Dr. Bransfield, to build upon what Dr. Fallon was saying, I'm curious if you can describe your clinical process of diagnosing somebody with neurological Lyme disease. Obviously, Dr. Fallon mentioned that neurological is not necessarily the same as psychiatric. So I may amend that to say, can you describe the process of diagnosing someone with neuropsychiatric Lyme disease?
Well, you look at, this is something that affects the entire body. So I think there's an infection, there's an immune reaction that infects multiple systems. So if you only have psych symptoms, and sometimes it's harder to tell if someone's been partially treated, so they don't have the musculoskeletal symptoms and they only have the psych symptoms. But you see this broad spectrum. And I think the greater the, what we call polymorbidity or comorbidity, the greater the broad spectrum of the symptoms, the greater the likelihood it's something affecting the whole body, such as Lyme, and or some other infection that has something that affects the entire body. And it's acquired. Like, for instance, attention deficit disorder, it's there from day one. It may not be recognized. But then if you get what looks like an acquired attention deficit disorder later in life, how else can you explain it? And so you're looking at those patterns, and in reality, with that whole thing about objective or subjective, that's actually very objective when you look at these clinical symptoms, and you can measure them objectively, and there's different ways to measure it. Whereas sometimes the way the lab tests are interpreted, the immune tests are actually very subjective. So you think of labs as normally being objective, but with the criteria that's used as a reference point, that really is subjective. So it's you have to, what do you put your credibility in? And I think what's happening in medicine today is there's with these algorithms and computer programs, and people are in these managed care organizations, you don't have enough time to do a very thorough exam. You have to see people every few minutes or so, and to get the thorough assessment that's needed, it's hard to do that in a time frame that is covered by most insurance companies. So part of it is like a system failure, the way our healthcare system is evolved, that it's easy to miss these complicated things where you have to think outside the box. And that's something that needs to change. We have to go back to the basics and how we were taught to do an adequate workup in medical school, and use judgment and individualize and pull it together and look at how it's evolved over time. I think that's how you have to make the diagnosis.
Sometimes spinal taps can be very helpful as well. There was a study in Europe where they showed that about 15 to 18% of the time, the blood was negative for Borrelia antibodies, but the spinal fluid was positive. So that can augment the evaluations.
You're fading again. Okay. You're back, I think.
Yeah, there you go. Back. But I agreed. I think that's a great point, Dr. Fallon. I know we had a whole social media program called Lyme Persists that dug into a lot of the autopsies that have been done, and gone into bones of deceased Lyme patients and still finding Borrelia in marrow and things like that. So you're exactly right. And I am going to get back to you quickly, but Dr. Bransfield, I wanted to follow up real quick as we move into our treatment section. I know you briefly just discussed your individualized clinical diagnosis for majority of patients that you work with.
Now you're frozen, okay? I'm not sure what your question is because you're still frozen. All right.
Can you hear me, Bob?
Yeah, I can hear you.
Okay. Well,
We're taking turns freezing up here.
we can run the show until Noah comes back.
Yeah, okay. Let me think. I think one thing, maybe one point to make is I've had identical twins that were bitten at the same time and had very different symptoms, which is interesting. So you have different vulnerabilities that different people have. Although when you have identical twins who were bitten at the same time, whoops.
Oh, that's too bad.
We lost, okay. I guess if he goes, the whole thing goes, okay.
Well, mine says we're still live on Facebook, so the recording may have stopped, but we may still be on.
Yeah, it looks like yeah, we're still on. Okay, so we might as well keep going even if
Yeah,
he's off.
let's keep talking.
Okay, all right. All right, so
I have the questions here that he was going to ask.
okay, go ahead. Why don't you go ahead with it?
So we were talking about how do you describe the process of diagnosing someone, and I faded out when I mentioned something about spinal taps. Maybe the computer didn't want me to talk
Okay.
about spinal taps, but I thought it was really interesting that in Europe, 15% of the time in patients with neurologic Lyme disease, the blood is negative, but the spinal fluid is positive. So sometimes it's helpful.
Although I think that's more you see that more with the European strains have more neurological pattern. And I don't know whether those numbers
Yeah.
might apply with the strain that we have here.
Yeah,
It's somewhat different. Although you do see some of those European strains
that's
here.
true. That's true. Yeah. Well, here's the next question. He was going to move into the treatment section.
All right, you're back. Okay. All right, treatment. With treatment, well, he's working on.
So the
I usually
treatment
I try to
questions.
treat with whatever hasn't been done before. So if someone's only been on antibiotics, I'd say, well, let's try the psych meds or let's try tweaking the immune system. If someone's only been on psych meds, and everybody that comes to me with Lyme doesn't necessarily come as a Lyme patient. I would treat a lot of treatment resistant patients. That's how I got into this in the first place. And a lot of times these people, were treatment resistant because they'd been on 20 different psych meds and nobody considered treating the condition that was driving the psychiatric illness, which was the Lyme disease. And then when you treat the Lyme disease, when you use an antibiotic approach, then you make headway. So you often do what hasn't been done before by other people rather than repeating the same old thing. And everybody responds differently. There's no two people that respond to the same treatment. There's such a diversity of how the people, not only in symptoms, but what they respond to.
Yeah. Yeah.
And it may have to do with all these different co-infections that we're still identifying that are part of it. And how do the co-infections fit together? Where does Bartonella come from? We don't see it so much in ticks. So why do so many of these Lyme patients test positive? It may be as opportunistic like they see with AIDS patients, or they get it through some other vector. Or all these, what other co-infections or different Babesia and different Babesia species, but it's this mixed infection that we're dealing with, and it's different with everybody. And one thing with the testing that comes up is if you look at, the CDC surveillance criteria is about 30, 40,000 a year. And one study showed that 3.4 million Lyme tests are done each year. And that was a few years ago. That was done about 5 years ago. So there's probably 4 million tests done a year now. And that means 1 in 100. 1 in 100 times, when someone says, well, I wonder if this is Lyme, let me do a Lyme test to see, only 1 in 100 times is a positive. What about those other 99 people? Were they, are all those people that did not have Lyme? We know by other CDC statistics that 500,000 people or so, or 176,000 have Lyme each year. So it's an awful lot are being overlooked, and that's kind of scary that we're missing all that opportunity to diagnose and treat these people earlier.
Yeah. I'd like to go back to something you were saying before, which is that if someone's been on antibiotics, you think about some other approach. If someone hasn't been on antibiotics and you think that the psychiatric symptoms are due to Lyme disease, you would certainly encourage antibiotic treatment. So that makes a lot of sense, to try something other than what you've been doing. And if you haven't been getting better from the same thing, you've got to try something different. And I know that, at least in my experience, a number of patients are very reluctant to try psychiatric medications, even though they have prominent psychiatric symptoms, because they want to cure the Lyme disease. But they may have been on antibiotics for like a year or 2 years already and tried numerous different types. And I find it troubling, actually, that they're not willing sometimes to try the psychiatric medication, because in my my understanding of this is that basically the spirochete can cause inflammation. We know that. It can cause inflammatory activation of the microglia of the brain, the inflammatory cells of the brain, and that can cause neurotransmitter changes. So once you have neural network changes and neurotransmitter changes, then even if you no longer have active infection, those changes are going to be there, and you need to have a treatment that addresses those changes. So I think many of the different psychiatric treatments can be helpful for patients with psychiatric symptoms related to Lyme disease. So I think that's important for people to realize. I've had success with the serotonin norepinephrine reuptake inhibitors.
Mhm.
So for example, some patients who come in with very significant arthritic pain or neuropathic pain, if I put them on a SNRI like Cymbalta, which is duloxetine, or other SNRIs, people can find a tremendous improvement in pain, and it surprises them because they didn't think it would help, and actually they do help.
I think you have to realize what starts it isn't necessarily what perpetuates it
That's right.
or makes it progress to the next stage. So that I think what occurs is it's like stopping an avalanche. You'd stop it one way at the top, but at the bottom it's different.
That's right.
Now, I think what occurs is when you get all these symptoms and you're chronically stressed, that makes you more immunocompromised. And if you improve the sleep and if you reduce what symptoms stresses the person out, then their immune system's stronger. And in many ways, the immune system is better at fighting this infection than we are with our antibiotics.
That's
So
right.
by treating those psych meds with those psych symptoms, or whatever it is that reduces the stress level, then that person's immune system fights better, and their immune system is more effective at fighting than what we have to offer with antibiotics. But I think because people come to you as a Lyme clinic, you may get a certain selection bias of people that think that way. Whereas I may get a different group of people that come to me as a general psychiatrist.
That's
and
true.
they want relief, although some of those people may be somewhat more biased towards the psych meds. It depends on, but sometimes you can educate people and they can understand and pull it together. But some people think, well, if it started that way, just, that's what you do with a sore throat. Why can't you do that with Lyme disease? But it's not that easy to treat. It just doesn't work the same way.
Right. I thought I mentioned something.
Real quick, I wanted to jump in and make sure if you can hear me or not.
Yes.
It looked like my video was still giving problems, and given that we have a lot of Lyme patients with sensitive, as we talked about earlier, I don't want to put it back on and potentially cause any issues. I did also want to jump in because we have a lot of Q&As from the audience, and I wanted to try to get to at least some of them before we reach our conclusion. Is there any other major pieces that you wanted to touch on in terms of treatment before we move to that section?
I would just invite people to take a look at our website, lymectn.org, which it refers to the Clinical Trials Network that with the Cohen Foundation grant we've been able to set up. It's a collaborative network of sites, which right now includes Johns Hopkins, Columbia, Children's National Hospital in DC. We're bringing on some new collaborators as well in the coming year. And right now we have John Alcott at Hopkins is doing a study of 3 months of tetracycline to see if that helps patients with persistent symptoms. At Hopkins, they're also doing a psychedelic study using psilocybin. At Columbia, we're doing a study of vagus nerve stimulation because that reduces inflammation in many studies of arthritis and lupus, and might be helpful in lupus, for example. It's been shown in small studies to be helpful for pain and for fatigue, and it can be given externally on the ear. So that's a study we're going to start in the next couple of weeks. There's a study at Children's National Hospital in DC for pregnancy and Lyme. And then other studies coming down the pike at Columbia would be neuromodulation studies looking at stimulation of the frontal lobe with patches on the forehead to reduce brain fog. and a study of intravenous ketamine for patients with depression to see if that improves cognition and mood. And if you check that website, lymectn.org, you'll learn about other studies as well in the year to come.
Awesome. Thank you, Dr. Fallon. So we have about 15, 20 minutes for some open Q&A before we move to our conclusion. I will start here with Carolina. She is interested in hearing how you might suggest educating a primary care physician who is not Lyme literate, that is resisting the diagnosis of Lyme made by another doctor. I know that's not necessarily neuropsychiatric specific, but it does seem like a relevant question. And maybe Dr. Bransfield, I will start with you since you're more on the day-to-day of a physician.
Well, for instance, an organization like invisible.org, where they have no charge CME programs they can do for education that is endorsed by the CDC, actually. So that's a way to get basic information as a starting point. And Dr. Fallon and I can't treat all the Lyme patients. You know, we get overwhelmed and there's just too many, and we have to expand the people. Everybody has to do their share. We can't just have, well, send them to someone who treats Lyme. There will never be enough doctors who treat Lyme. Everybody has to treat it. Everybody has to get some basic knowledge, but they have to get it gradually. There's different platforms for educating people depending on how much they want to do. I've been doing one with psychiatrists for 23 years on the internet, and it's there's like 700 in that group, but there's still not enough. So look at one of these educational programs and they can learn. You hope someone has an open mind, and that's what medicine is. You have to be educated by your patients and learn from them. And medicine is a never-ending educational process in a person's career.
My experience with family medicine doctors is that actually they're extraordinarily open to wanting to figure out what the diagnosis is, and including considering the possibility that infections might be causing some of the multi-system symptoms. Family medicine doctors are used to seeing patients with chronic long-term illness, and they often work with social workers and psychiatrists to try to help their patients. So I honor the family medicine doctors for what they do, and we need more of them interested in Lyme and tick-borne diseases.
Carolina, I hope that answers your question. Moving on, I have Monica here of the Colorado Tick-Borne Disease and Awareness Association. She has a question regarding PANS. She said, for children and teens that suffer from PANS, anxiety, depression, suicidal ideation, etc., have you seen a significant improvement with the use of IVIG after treatment or concurrently with antibiotic treatment? What is most effective? Low dose, high dose, frequency of duration of treatment? Can the brain heal? Now, before either of you answer, I do want to state that as a nonprofit organization, we can't give anything too specific about treatment, and obviously every patient will be different. The responses of the doctors are the opinions of themselves and their own experience in treating. So I will leave that open to either of you two who may have more experience in that realm.
These autoimmune cases are very challenging, and it's almost like they have delirium, and they can sometimes jump out of windows, crawl under furniture, take their clothes off, be aggressive, and it can be sudden onset, what might be called the sawtooth pattern, where they get exposed to that autoimmune reaction. And IVIG can help, although it doesn't help everybody, and it's one of the many things that you try. And treating the symptoms, treating the infection, and particularly anything else that tweaks the immune system. And you always, like I say, have to individualize it with every patient.
Yeah, I think it's worth also knowing that there are actually 3 really good articles that were published in the Journal of Child and Adolescent Psychopharmacology with Jenny Frankovich as one of the key authors, looking at describing guidelines for the treatment of PANS and PANDAS. And it starts with, first of all, a good diagnosis. And then it starts with, if there's an infection, treat the infection. Actually, it starts with treating the psychiatric symptoms, because those are where they're prominent. They come in with OCD symptoms or eating disorder symptoms, or attentional problems. And then it goes to treating the infection if you find that there's a treatable infection underneath it. And then if that's not working, and if you still think it's an immune-mediated problem, then you might move on to the more intensive immune modulatory treatments. But you might start with non-steroidal anti-inflammatory drugs, less intensive, and then eventually you might go to IV immunoglobulin or other therapies. Now, there's no good studies that have definitively proven that IVIG is helpful for this, but there are certainly studies that strongly suggest it. And the original study done by Sue Sweeto did show that IVIG was beneficial, but it was a very small study. And a later study that was done at Yale and in a consortium was more ambiguous about improvements. So there's still some question about the benefit of IVIG, but clinically, I have seen it help some individuals considerably, and I think it certainly does have a role.
Awesome. Thank you both for your responses to that. I know a lot of these questions, and we have way more rolling in. I do have to state that we won't be able to get to all of these. So apologies if you submitted a question and we aren't able to answer it. For those of you who asked about the websites, I dropped them in the chat. The first is the Clinical Trials Network, and the second is Invisible International, which is the continuing education courses for free. And then I also see Alex log link to the Copenhagen study. That will come later. That'll come tomorrow morning when I send the recording around to everybody. Dr. Fallon is going to get that to me after this. He's doing a great job, very focused on answering questions right now, so not asking to multitask. Let me look real quick. Answer maybe one or two more before we move to conclusion. So this one, I think, will help answer a couple of questions, and this is specifically for you, Dr. Bransfield. Basically, how can somebody make an appointment to see you? Are you still accepting patients currently? Along those lines.
Don't traumatize my office staff. We get a dozen calls every day and begging and pleading, and we then keep referring, and you probably get it too. It's now there are the people, and that's why we have to train more. We have to train more psychiatrists and doctors. We have to train more in every specialty to deal with these cases. We are doing a training program, by the way, in Hershey. So what's good is that if these people can get a doctor, like the other comment about the family doctor, get someone who has interest, who's open-minded to expand their interest, who's willing to learn more, that's the best way to do it. So we have to expand our ranks, and we can't.
Bob, tell us what you're doing in Hershey.
Oh, it's ILADS is having a meeting in Hershey, and this is in March, and it's our basic educational program for doctors. So we do this every year. We did it down in Florida at our ILADS meeting, but we're also doing it at Hershey in March, so that if someone wants to learn the basics, they can go for a one-day course, and we cover the basics. I'd be doing the psych, the child psych, and then we do case history, and other people would be doing other parts of that. So it's where someone can go for the day, and they can learn the basics, and then they can have some way of having a starting point for dealing with these cases. That's a good way to do it, and it's and then they can interact and ask questions, and it's with something we've been doing for a few years is setting this up, and we're doing more of a standardized program now that we repeat it every year, but we repeat it more often than that to try to expand the ranks of people that treat this. Or if, let's say with the psych, if you have a psychiatrist that you know that wants to learn more, then get their name to us and then we can put them on the list of the discussion group so that they can learn.
So quick plug for Project Lyme while iLads has been mentioned. We were very happy to sponsor the annual conference this year and are looking to continue our involvement with iLads and their doctor education, because while we do a variety of things, educating doctors and increasing the number of literate physicians is extremely important to us. So thanks for being a part of that, Dr. Bransfield, and definitely encourage people, as he said, to direct doctors who are interested in learning more that direction. So last question I think I'll ask before we move to conclusions here is an individual asked that sleep might be a place to start for those with neuropsychiatric symptoms, but what might you suggest to help people sleep, especially those who are suffering with issues with it because of the underlying fatigue associated with Lyme disease?
Well, think of sleep. Think of the terrible triad: non-restorative sleep, fatigue, and cognitive impairments. So if you get the restorative sleep, and you have the deep sleep in the beginning of the night, and then you get the REM sleep later. But if you get sufficient deep sleep, then that triggers growth hormone, and that helps with adaptive immunity, and it helps with endocrine functioning. It reduces pain. So it's really one of the most critical places to start. Now, just about every FDA-approved drug for sleep only helps people sleep longer, but they don't really improve quality of sleep. So there's certain meds that improve quality of sleep, such as trazodone or mirtazapine, and some of those. So that's the quality of sleep, particularly deep sleep, is what has the greater impact on immune functioning. So we particularly want to shift towards these deep sleep promoting drugs. And what I always like to see is that someone says they feel well rested in the morning. And then people can't sleep for a number of reasons. Either they can't fall asleep, and there's different reasons why they can't fall asleep. They can't turn off their head, they can't relax, or they rest their leg, and then reasons why they wake up in the middle of the night. It might be nightmares, it might be reflux, or it might be palpitations, some often different medical issues, and then early morning awakening may be more commonly depression. So you have to look at why that person isn't sleeping, or it could be sleep apnea. You may have to address sleep apnea and correct that, and correct what's causing the lack of sleep or the lack of restorative sleep. And some people sleep a huge number of hours because they have poor quality sleep. So when I look at, if I were to go through all my patients and I say, what symptom do we attack first? Sleep is usually number one. And then, and that's usually head and shoulders above everything else.
I agree with that completely. Yeah.
Yes. So, and that often can do, that is an antimicrobial treatment, basically, because it makes your immune system stronger when you sleep better. If you get the cold or the flu and you curl up in bed, we call it sickness syndrome, then it helps you recover. The people that don't do well are people that are stoic, that fight it and they don't let themselves recoup and recover, and they never recover. But if you allow your body to heal, your body's smarter than I am, and let your body do what it knows how to do to recover, instead of trying to override it with things that are less effective than what nature has already designed for us.
Dr. Fallon, I know you said some, but did you have anything else to add to that?
I thought that was a poetic and a beautiful response about sleep. And I totally agree that if you're not sleeping, you're going to be cognitively impaired the next day. You're going to have pain syndromes. You're going to feel sluggish. You're going to having brain fog. So if you can get the sleep corrected, that can do a lot.
Okay, thank you so much. Anybody else who submitted questions, I appreciate your interest, and I wish we had more time to get to everybody. Feel free, if you would like, to forward your question to info@projectlyme.org. That doesn't guarantee that I'll be able to get back to you with something, but it may give us a little bit more opportunity to present you with an answer should it be within our wheelhouse of information. Outside of that, I want to move on to our conclusion here and give each of you an opportunity to just provide some sort of an insight on the current state of NeuroLyme and kind of what comes next from this webinar to all the work that you're doing at Columbia and all the work that you do with patients. And Dr. Fallon, I think I'll start with you.
Well, my main message is that there's a lot of reason to hope. I think the future is bright. There's a lot of interest in post-infectious syndromes in the world right now. So what we learn about long COVID will be helpful for long Lyme and what we for some of those patients. So I think that's very promising. I think the approaches towards neuromodulation that are emerging right now are really interesting and offer a non-medicinal approach to help people with inflammation and cognitive problems. So that may be very helpful. So I'm highly encouraged by what's going on in the world right now. And I also think the studies on different antimicrobial approaches that are in animal models being studied, I think are very encouraging. So I'll let Bob say the next.
Well, I think we need to have people work together who don't normally work together in a team. For instance, Brian's made a comment about building bridges, and so have I, that psychiatrists and infectious disease doctors don't often work as a team, but we have to do that. And because this spans so many specialties, we have to do a collaborative effort. We have to be careful of power struggles and guarding turf and things like that, and look at how, because these things progress over time, you have to connect the dots. And I think if we pay attention to this, there's a lot of potential. And it's not just what we call Lyme was a syndrome that was recognized, but these are complicated infections that have many different pieces, many different infectious agents, many different immune reactions, many different pre-existing vulnerabilities. So it's a very complicated formula. And everybody has to be approached differently for that reason. But when we pull it together, and if we approach it this way, I think we can really prevent a lot of disability, a lot of suicide, a lot of mental illness, a lot of drug abuse, a lot of aggressive behavior that we otherwise deal with that could be prevented by early recognition and early treatment by a greater collaborative effort. And we have great potential to really change the world for the good by paying more attention to these things and catching them earlier, preventing them, diagnosing them earlier, having more effective treatment earlier. So there's great potential by being more attentive to these issues. When I was in med school, everything was Freud, and we've evolved from there. We have to look at this is maybe one of the major contributors to mental illness, is certain kind of infectious diseases at a certain point in life where that somehow sensitizes someone. And let's do everything we can to help people be healthy.
I think that was a great way to wrap up. Thank you both, Dr. Fallon and Dr. Bransfield, for providing a lot of in-depth work on behalf of patients and leaving this webinar off with a bit of hope. Thank you to all of our attendees for coming today, listening, and hopefully we've been able to offer something of benefit to you. As I mentioned, I'll be sending the recording around to everybody tomorrow, along with the link to the research Dr. Fallon mentioned. Thank you again. Thank you, thank you, thank you. Keep an eye out for upcoming events. We have one next Thursday with Dr. Tim Haysted of Duke, talking about the development of Lyme treatment. So if you're interested, I invite you to sign up. Aside from that, I bid everybody a good night, and thanks again to our panelists.
Thank you, Noah.
Thank you, Noah, and thanks for doing this. You help a lot of people by it. And good night, everybody.
Good night.
Bye, Brian.